All right. Welcome back, everyone. We are pleased to be joined again today by Dr. Lapke. How are you today, bud?
I'm good. Thanks for having me back.
Yeah, you bet. And Josh, too. It's good this feels normal. This feels like we got kind of back to the crew again. So, today's topic is going to be around prostate cancer. So, with September coming up, this is a good opportunity for us to, talk a little bit more about the awareness of prostate cancer, some prevalence, some leading causes, and some early detection. But as with the last episode that we did with Dr. Perlman, the idea here is to provide resources, do our part, raise awareness, and make normalize the conversation. So, this is probably one of the most common leading causes of cancer, as I understand it.
Correct. In the U.S., approximately 1 in 8 men will develop prostate cancer. Worldwide, it is the second most common cancer and has the 5th most common cause of death in regards to cancer worldwide. But in the U.S., again, it's the second most common cancer, but the second leading cause of death with cancers.
Yeah, behind lung cancer, I believe, is what I read.
Yeah.
And we were talking a little bit off cam about, sort of maybe the reasons why that may be, why America really struggles, or why it's more more prominent, or why there's a higher risk here. And we were sort of associating that with the diet a little bit.
Yeah, I mean, I think, again, we see a lot of morbidity, mortality with a lot of disease processes in our country. And I do think a lot of it does lead back to our American diet and sedentary lifestyle. I mean, one of the things to reduce your risk for prostate cancer, one of the top 2 things are exercise and diet, and normalizing your weight, or, avoiding obesity. So, that definitely points to that. I mean, there are some other factors, certainly certain races, at higher risk, much higher in the Black population, significantly lower risk in the Asian population. So, you're seeing some of that, but there's also, they're finding more and more a big genetic component to prostate cancer.
Sure.
Like significant.
Sure.
And they've found a number of genetic mutations that if you have them, you're definitely at increased risk.
I think it's the BRCA genes.
Yeah,
that's correct. Which is very, very prevalent in women with breast cancer and ovarian cancer. So if there's a family history of any of that, like women are screened at young ages, and that's where you kind of saw, probably a few years ago, those it was kind of the elective bilateral mastectomies and getting the ovaries removed and the breasts removed, just prevention of, like, mom had it, grandma had it, great grandma had it, you're probably going to get it too. So these women who had kids and they were all done having kids, they would just have their breasts removed, and just to reduce the risk. Not that easy with the prostate, though, unfortunately.
Nope.
Yeah. So for the people that don't know what that is, what its function is, let's do a little bit of education.
Sure.
Because we gotta make sure that people know where and what. So location and function, I think, is maybe where we should start.
Yeah. So the prostate gland sits immediately beneath the bladder. Okay. And the urethra, which is the tube that drains the bladder, runs right through the prostate gland. And it's only about the size of a walnut. So it's a pretty small gland. The main function of it is it secretes fluid that helps nourish sperm and helps carry sperm. There's also 2 glands on the side of it called seminal vesicles, and they also add to the fluid in the ejaculate. So that is the function of the prostate gland. Unfortunately, as all of us men get older, well, the prostate gland gets bigger. And what that causes is, or can cause, is urinary difficulties, something called urinary retention. Because the fact that the urethra goes right through the middle of it, if you think about it, that gland gets bigger, what's it going to do? It's eventually going to squeeze down the diameter of that urethra and make it more difficult to urinate. And, my years in the ER, I can't tell you how it is so common. Almost every shift, you'll get an older gentleman who comes in and they can't urinate at all. And it's like, that thing has finally gotten so big.
Oh, Jesus.
Yeah, it's just totally obstructed the urinary flow. So enlargement with age is extremely common. Unfortunately, with age, our risk for prostate cancer continues to go
Yeah,
up.
because number one risk factor is age.
Yep.
It would be 65 or older is most common.
Yeah.
So that's what they would consider would be the number one like studied risk factor that we can actually say like your age puts you at a higher risk for prostate cancer than anything else that we know of right now.
Yeah.
So
Yeah, I saw it was on average just about age 66.
Yep.
About right where it was at.
Yeah.
and we'll talk about why that's kind of important later for treatment options. So
Right. I mean, it's always been known as a cancer of the elderly.
Yep.
Right.
Mhm.
I mean, especially when we were back in school and it's like, it's common in the elderly, and usually you'll die of something else before you'll die of prostate cancer. Well, that's not necessarily the case anymore. Like I said, the most recent statistic I read was 60% of the cases are diagnosed in men over 65. Well, that leaves 40%. And I've known more and more guys in their 50s getting diagnosed with it.
Yep. Because it can be a slow growing disease,
Yep.
very
Yep.
slow growing disease.
Some can be high grade and more aggressive, but generally it's a slower growing, but not without problems.
And that's why it's a complicated disease, because it can be there and it can just be smoldering and smoldering and smoldering. And one of the diagnostic tools we use is a PSA, which is, the more we kind of use it, the more we know it's maybe not the best test.
Yeah.
When we do medical tests, as far as lab work or if we're using strep or whatever, we refer to them as being specific or sensitive, right? And the sensitivity of a test, if it's positive, that means that there's a high likelihood that there's something there, right? And if it's specific, then that means that if that test is negative, there's a 99.8% chance that test is truly negative, right? So it's a poorly sensitive test, but and it's always been kind of referred to as a really good specific test, but I don't think that's necessarily the case, right? I mean, you told me the story of your doc or your friend that had just a little bump and it was still normal and found out he had disease.
Yep.
So it's not a reliable test. It's an easy one, but that doesn't mean it's reliable. And so therefore it can be hard to diagnose, especially early.
Yeah.
Because we don't want to do unnecessary biopsies and other tests if we don't have to.
Yeah.
So it gets complicated.
Josh and I have talked about this just in regard to patient care, and at Limitless Male, we do a monthly lab panel, and one of those lab panels consists of PSA. And the reason we do it, it used to be thought of, or does testosterone therapy cause prostate cancer? Well, there's been multiple studies, and they have shown, no, it does not cause prostate cancer. But if you have prostate cancer, testosterone can certainly help potentiate the growth of that cancer. So at Limitless, we take that very seriously. And so in our monthly lab draws, we monitor PSA levels. Well, normal range is anything under 4.0. So generally like 1 to, or you can have a level of 0.6. So, a lot of people would think, well, as long as I'm under 4, I don't have prostate cancer. It's normal. No, not the case. So you could be following a guy for quite a while, and let's say his levels have always been 0.6. Well, all of a sudden he bumps up to like say 1.5. So you'd be like, well, what's the problem? He's still way under 4. But no, that is a telltale sign of there's something going on with that prostate, because the number you not only look for is it less than 4, but you look for doubling of the number. Yeah. So if it's doubled, two things could be going on. They could have prostatitis, which is an infection in the prostate gland, which is a pretty common, prevalent thing. Or it could be an early indicator of prostate cancer. So that's where Josh was talking, where it gets a little sticky. It's like, oh, what do we do with these guys? They're below 4, but now they've bumped up a couple times. Where do we go from there? Yeah. Without delving into, okay, now we got to do a bunch of tests and we got to get biopsies right away, which aren't without risk and they're uncomfortable, etc. So that is the tough thing about PSAs.
Are you looking for consistency in those numbers? More, I mean, if a reading is going to be up once every 3 or 4 months, it's like that's maybe normal, but
exactly. I mean, like again, we were talking, you see it 1 month. I mean, you hope to God that someone's not just going to jump on that and say, oh, we got to get biopsies and stuff. Yes, you look for consistency. And if there's a steady rise, or, you more than double and you hold there for a while, let's say a few months or more, then you start, it's like, well, maybe we need to look into this a little deeper. In the past, there hasn't always been great options, but now, with research, there's a lot better options for helping to sort things out. One thing I was reading, I don't know if you've ran across this, Josh, but it's a test that Cleveland Clinic came up with, and it's called the 4K scoring. And what they did, they followed 20,000 men in Europe and the U.S. for 10 years, and they followed 4 total biomarkers. So like PSA level, it's the full name for it is prostate-specific antigen, and it's an antigen that gets released by the prostate gland, and it's measurable in the blood. Well, they followed 4 other biomarkers or in the blood, and they look at them, and then they came up with an algorithm calculation based on age, other risk factors, etc. And this test is much better than just a straightforward PSA. And it really helps to delineate your high-grade cancers from your low-grade, helps delineate cancer from prostatitis. And by following this algorithm, they have reduced needless biopsies by 50%, which is very huge.
Huge, yeah. The risk of sepsis from a bad biopsy is
really bad.
It's there, because I mean that's again.
And for those who are not medically inclined, what a sepsis is, so I've heard it, and it doesn't sound fun.
So widespread, like it's a widespread immune response to infection.
Gotcha. Okay.
Yeah, it's nasty. It's no good. You don't want it. I mean, it triggers a lot of people to work really hard. Antibiotics, and I mean, it kills people pretty frequently.
Yeah, death rate is
enough
high,
to not. Yeah. So, and the interesting thing about the PSA test is you got to look at certain patients that I work with. Say it's October, November, January. Their PSA is fine. Their PSA is fine. April rolls around, that PSA goes up, and I'm like, what's going on, man? Like, what do you do? Like, oh, nothing. Like, what do you do for, like, what's fun? Do you ride a bike? Are you a truck driver? Like, oh yeah, I ride my bike. Well, bike seat is like when you sit down, it rides perfectly on that prostate, and you're putting pressure on it, and you'll see that prostate go up, and then once it gets cold again, it'll trend back down. So it's another thing we have to consider all those things and be careful so we're not doing unnecessary tests on patients just because the guy's riding a bike. He's trying to do the right thing for himself, and we're sticking needles in him and taking biopsies. And I think the other hard part about diagnosing prostate cancer is a lot of the symptoms are similar to just normal benign prostatic hypertrophy, which means just benign, non-cancerous growth of the prostate. It happens as we age, but it's the same, very, very similar symptoms. Yep. And we don't have we don't really have any good imaging for prostate cancer, right? Breast cancer, generally, they can feel lumps and bumps, and then you do mammographies, and there's really good imaging that you can do. it's just in such a spot that it's really hard for us to get good imaging to see a tumor. It just makes it very challenging, and it's kind of why we brought this up, and we're going to talk about it and being proactive in screenings and so on and so forth.
So some of the symptoms, because you mentioned that before, it would be weak or interrupted urine.
Mm-hmm. Yeah. Weak stream.
More often.
Mm-hmm.
Yep.
The frequencies. Obviously any pain or discomfort. Starting, stopping.
Mm-hmm.
Yep. Yeah. The classic one is the guy goes to the bathroom, zips up, and goes to wash his hands, and can't get back and he'll piss his pants, or because it's like,
sure.
wait, the bladder wasn't empty. Yeah, the bladder was not empty. Yeah.
Well, I suppose he doesn't have any control. I mean, anyway, you're
100% right, because that's guys just they don't. That's not normal, right? What the hell's going on? Why am I going to piss my pants again? And that's not normal, right? That's that's something that's like, if you haven't gone to the doctor, maybe it's probably time just to go at least get a blood test. And I mean, the other fun part is the digital rectal exam, which again, that's a hard one because it's dependent upon the operator. Because if you don't have a lot of experience doing that exam,
well, studies have shown it's again not a reliable test or physical exam for finding prostate cancer. Mm-hmm. I mean, we were all taught to do it in medical school and do it religiously, but studies have shown it's really not that effective.
So when you're looking at, let's say they take a biopsy, right? Or your PSA tests were alarming, and so that you move to a biopsy. I feel that would be the next.
Well, so the imaging that's most used is ultrasound, and they'll use, because of the placement of the prostate. It sits right, next to the rectal area, so they'll use like a rectal probe with the ultrasound, and that's where they found that they can probably get the best imaging. To be honest, I don't know where they're at with MRI. I haven't heard or seen a lot of it. Have you, Josh?
I haven't. No, and I think as ultrasound has gotten so much better, specifically over the last probably 10 to 15 years, because it's so widely used. It's cheap, it's easy, especially like in the ICUs and the ER. Mm-hmm. It's replaced a lot of different things because it's such a good imaging modality. That's probably, those things look, you look at it, an ultrasound from 15 years ago compared to now, it's like 4K compared to just like Tecmo Bowl.
Absolutely.
It's true, man. You can see fine detail on these things, and that's good, right? We need that technology so we can, it's no different than a transvaginal ultrasound, right? I don't want to ultrasound.
No, I think if anybody listening is going to really appreciate that you pulled in Tecmo Bowl.
Yeah.
That went
it depends on the generation, right?
True, but that went to the heart of it. I thought it was a very good analogy.
Yeah, it's Tecmo Bowl to Madden 22.
Yes.
Yeah. So, generally they'll proceed with an ultrasound, and, they'll good physical exam and a comprehensive lab screen, and then decide, if they'll do a biopsy or not. And the biopsies are ultrasound guided. But like Josh said, the risk, high risk of infection rate with it, not only sepsis, but an infection in the prostate, prostatitis, which those are really hard to get cleared up. There's, it's not uncommon. You have to treat a man for a month with antibiotics to get it cleared up.
And the hard part about the biopsy too, the anatomy of the prostate is such as that there's lobes, right? So it's not just a one shot. Oh, I got it. I got the whole prostate. You could do a prostate biopsy, and if you don't get the right spot, you could miss the tumor. Yeah. Now, they're real. These doctors are they're amazing at it. Sometimes they'll do multiple biopsies, which I think that's kind of the moving towards the standard of care.
Because otherwise, it's too easy to miss.
Yeah, it's not worth missing. You'd rather poke somebody 3 times than do one and be like, oh no, you're fine, and the next thing the guy has metastatic prostate cancer. It's a bad look.
So
they and in that event, so they. You look at the cells and you have abnormalities in the cells and because they're growing really fast or they're dying too slow, as I understand it.
So, obviously we talked about testosterone is the hormone that stimulates prostate gland, and so if you have prostate cancer, it can stimulate that growth. And when cells start dividing at a rapid rate, that's what most malignancies are. The rapid growth, more rapid than what takes place in that normal gland or organ or whatever else. So almost all prostate cancers, they'll find two different what we call grades of cancer going on, and out of that two different grades, they score them, and so the most common used scoring system for prostate cancer is called the Gleason score. Okay, so and they do it based on the two different cell types they find. Your highest score is a score of 10. You don't want to have a score of 10.
Right. That's not good.
You want yours found when your score is like 6.
So it's like golf. You want like a golf score.
Now, that doesn't mean that your prostate cancer has gone beyond the prostate. That is strictly defining the malignancy within the prostate gland. But of course, the higher score, the higher your risk is that it has spread outside the organ.
Got it.
The prostate gland is encapsulated. It's got a capsule around it. But the risk is if it gets outside that capsule and gets into lymph nodes and other tissues like the seminal vesicles, the bladder, the most common place it metastasizes is to bone.
Yep.
Wow.
Yeah.
So cancer is really interesting, and the organs that you get cancer in, you can kind of trace where it's going to go, and we do that through just the blood vessels that come in and come out of it. So bone is common because bone is there's blood everywhere, right? But then the next common would be liver, lung, and the reason why that is the veins that drain the prostate flow right up into the major vein that comes back to the heart, which goes through the liver and then goes to the heart and then to the lungs. So you're kind of right along the way station of while prostate cancer itself really isn't dangerous,
right?
Once it gets outside the prostate, it's going to 3 bad spots: bone, liver, and lung, which are, you get those, that's not a good prognosis at that point. So that's why prostate cancer in itself, like we said, is not super dangerous, but it's where it goes is what kills people.
Yep.
And again, it's so hard to diagnose and so hard to know you have it. It could be too late by the time you find out, because sometimes it's like, oh, I have shortness of breath, or I have hemoptysis, which means you're coughing up blood, and then you go in, you got a tumor in your lung, but they find the origin was actually in your prostate, and that's when it's very, very serious. And
so and with that analysis, there's a grade, right? And then there is like a stage, as I understand it. And maybe this is common with cancers. And I'm trying to play the dumb guy in the room who has questions.
You're dead on correct, right? Because not all cancer cells are made equally, right?
Yeah.
Like there's like if we were to grade like skin cancer, like a basal cell carcinoma is, we don't worry about that. You just clip it off and move on. Now a melanoma, that's the cancer that kills you, right? It's a higher grade, more aggressive cancer, right? And the way that cancer is staged is kind of funny because people think, oh, stage 4 cancer, like you're dead, which is not necessarily the case, right? Stage 4 cancer, if you have metastasis to anywhere in the body, you're automatically at stage 4. So like if you have prostate cancer and it's in the bone next to it, stage 4 cancer. Or if it's in the lymph nodes next to it, stage 4 cancer automatically. Okay. It doesn't mean it's widespread, your whole body's covered in cancer, you're going to die. It's not the case. But the grading, and correct me if I'm wrong, is just the aggressiveness of the cancer.
Exactly.
The staging is how far it's progressed within your body. Yeah. Does that make sense?
Yeah.
Okay.
Yeah. It was good. Those two pieces of great. Because guys are, if in the unfortunate event that anybody listening has to go in and talk about that, there's verbiage being discussed with you and your urologist or whoever else that you're working with, that those would come up. Those two things.
Absolutely.
You have to know that, right?
Yep.
And Josh is absolutely right. I mean, like he said, the grading is the cell type, which the majority of prostate cancers are called an adenocarcinoma, which is not going to mean anything to our people listening if they're not in medicine, but that's just what the cell type is. But then the staging is, where has it gone? And there's multiple things they look at to stage different malignancies correctly. But that's how it's done.
Yep. And the interesting part about what you said earlier about the cell type is, while it is kind of a runaway train, that's what cancer cells are, you have these prostate cancer cells that have mutated into a different type of cell that just replicate. But when you said they're dying slowly, cancer cells don't die. They live forever. So they have at the end of our DNA, we have something called a telomere. It's like a little band that kind of degrades over time. I think we talked about this before.
In the fatherlessness episode.
Yep. So just our telomeres, as we age, our cells that degrades, and that eventually, once all the telomeres, we die of old age, right? Yep. Cancer cells, the telomere does not degrade. And so, like I told you, the HeLa cells that we used in my biology class was from a lady who had cervical cancer from the 50s or 60s or something like that. So that's the other dangerous part about them. That's why cancer is so hard to fight, is because the cells are constantly dividing at a way more rapid rate than what our body's used to, and they're hard to kill. Yeah. So, yeah, that's the tough part about them. That's why, again, all cancers are serious, but prostate cancer, the prevalency, and it's 50% of the entire world is at risk for it just by being a male and aging. Yep. This is why we're talking about it.
So I think the next conceivable place to go is like early detection and being proactive in this whole thing. Yeah. So early diagnosis, because I think you've obviously, like with most things, if you can get in front of it, you can prevent it, and certainly you can prevent the spread of it. So how is it detected, and talk us through like early diagnosis and detection?
One thing before we really get into that, I want to take a step back and talk about risk first. So, because I feel if the guys can understand their risk and the significance of it, then they're more likely to come in and be tested, be screened, get that done. As we talked about before, your risk factors are obesity. They generally say, a body mass index greater than 30, and that's a calculation that we look at. A diet high in fat, low in fiber. If you eat a lot of processed food, processed carbohydrates, that definitely increases your risk. Sedentary lifestyle, smoking definitely increases your risk. Alcohol in excess can increase your risk for all malignancies.
Thanks, Doc. Put a damper on the whole.
Our next episode will be the
I'm right in there. I'm right in there with
how
you.
How hypocritical can we be?
Yeah,
Let's find out how far we can swing the pendulum the other direction.
Yeah. Age and then family history. Yeah. And so like in my case, my grandfather, my dad, and 2 of his brothers have all had prostate cancer. Oof. So I've always said it's not a matter of if I'll get it, it's a matter of when. So guys have to know and be aware, if they have a family history of it, then they really need to be on it and be taking the screening process seriously.
Just swing by the office anytime, Doc.
I'll make an appointment.
I'll do low salt that day.
You got to bring your own Vaseline for that, I believe. It's BYOV.
Yeah.
Yeah, we don't have any of those little jelly packets that we had when we were students. You rip them open and just pull them
I know, what's up with that?
Maybe we should get some.
Yes.
Oh, wow. Talk to the, trust me, you'd rather, you don't want it dry docking. You want that.
Yes, sir. Okay. So, and obviously it's something that if we're in front of, it can be cured. But I feel like a lot of the things that are the preventative measures on most of all of our episodes are pretty fundamentally the same.
Yeah, it all goes back to the same, doesn't it?
It's like, dude, just get off your ass. You got to move. You got to eat better.
Yeah.
There's just no other way around it. Yeah. You can't buy it at Walgreens. It's not going to be done for you.
Yeah.
It's like you have to do it. You have to do it.
It's a lifestyle choice.
Yeah,
absolutely.
Yeah.
Yeah. So, and then as we talked about, it's getting that PSA level. It's understanding what it means. Having some a provider that's really on it and watching. Is it, what is it this year? But what was it the last 3 years? and, really going to that length to compare and see how things are changing, monitoring for other symptoms.
That's why I like that we do our monthly blood draws. While we don't diagnose or treat prostate cancer, we can provide a wealth of data to urologists and oncologists to say, hey, this is Joe's labs, his PSA since he started seeing me 18 months ago. I have 18 PSA draws. You can watch the trend.
Yep.
That really helps. Because a trend is more important than an isolated number.
Yeah.
Like I said, like you get on a bike and you ride a bike, your PSA goes up. That who knows? Was that because the guy was on a bike, or is it because he has BPH, or is it because he has prostate? But and again, the trend doesn't tell that story, but it allows us to see what's been going on in this guy's life and how the numbers have adjusted. And while it's not necessarily practical in like a primary care sense, but it allows us to do that at Limitless Male. It's a super helpful tool for patients and for us too.
Yeah. As Josh was saying earlier, I mean, the PSA is not a perfect test. But back in 2011, the U.S. Preventive Service Task Force came out and recommended against screening. I don't know if you were practicing back then, Josh, or I'm just showing my age.
When was that?
2011.
No, it was my second year of undergrad. So yeah, I was a late student though. So
yeah, there you go.
I would have been if I would have been a good kid when I was growing up, but I wasn't a good kid. So,
well, what we saw by that is delayed diagnosis, and then all of a sudden, years later, we're diagnosing men with advanced prostate cancer. So while it's not a perfect test, it's definitely one that needs to be done.
So let's address the guy that does not come into Limitless Male each month, that is aging, and is not likely having this conversation with his primary care. Would men be wise to, as they age, work with urologists directly, or is it not until there's a problem?
I think it can be done through a good primary care provider or a urologist. I mean, certainly as we age, we're at risk for other issues coming up, which then would require a urology referral and further workups. But just like at Limitless, obviously we're not urologists, but we screen for it very thoroughly. And, that's where it starts. It doesn't have to be done by a urologist. There's not enough urologists out there to be screening every man, 50 and above. Yeah. And I'm sure they don't want to be doing that.
That's a bandwidth thing.
Yeah, I mean, their training is as surgeons. And, and so, they'll gladly take the referrals as they're appropriate, but there's not enough of them to be doing all the screening.
Yeah, that makes sense. Okay, so we've gone into some of the testing and the early diagnosis. What else is there to know? Some risk factors, some prevention.
Well, I guess one thing we haven't talked about is, when do I start screening? Mm-hmm. What age? Yeah. I pulled information from 3 different sites: the U.S. Preventive Services Task Force, which they make recommendations on all kinds of different screening, health issues nationally, the American Urological Association, and the American Cancer Society. So the task force, they recommend screening starting at age 55 to 69. They don't recommend screening after 70. And the reason for that is because generally prostate cancer is a very slow growing, smoldering type malignancy. And of course, they take into consideration life expectancy. And so after that age, you're a lot higher risk for dying of many more other things than prostate cancer.
Right.
So why put yourself through
why put yourself through it? Okay. But
which is very humane, right? Let's not. I don't want to gloss that over. People think like, well, I don't care. No, it's because at that point, we should all be worried about the quality of our life.
Absolutely.
And 70 years is not a long time, but
Yeah.
It's a good haul.
It is,
Yeah,
right? And it's not worth living the last year suffering from chemo and suffering from prostate surgery. It's
or even urinary incontinence and all the problems if you have prostate removed.
Yep.
Now, the American Urological Association, they recommend 55 to 70, but if you have a family history, like a first-degree relative who's had prostate cancer, or African American, they recommend starting to screen at age 40.
So would that be like 45 for me, since I'm half black?
It might be.
That's so funny. I'm just trying to figure this out.
So what's in your drink today, man?
I'm not trying to make a joke, but it's just like,
no, yeah,
it's
I'm gonna look that up for you, Josh. I'll get you that answer.
Talk to Dr. Perlman. I'm sure she would be like, I'm never coming back on the show ever again.
And they do recommend screening men after age 70 who are in good health. And that's the problem. I mean, we're seeing more and more men, or women and men, live at very advanced age. I mean, 70-year-olds who are highly productive and in great health. So, I mean, while these recommendations are great, Aaron, you and I were talking about it before the show, it still comes down to everybody has the right to be informed and to make their own decisions along with their physician what's best for them. Yeah. I mean, it's easy to have recommendations, but they can't be 100%, right? Because every case is different. Mm-hmm. So just something to think about. American Cancer Society, they recommend starting at age 50, but age 40 if you have a family history.
And so when we say screening, are we talking about just PSA?
PSA.
PSA plus DRE, which is the digital
rectal
exam?
They were kind of plus minus on the digital rectal exam, but this was strictly for getting PSAs. So really, I've always gone by age 50, but if you have a family history or African American, start at age 40.
Yeah, like that's kind of
I think just to make it easy, that's kind of a pretty safe rule to go by.
Yeah. That makes sense.
Yeah. Yeah. I mean, again, early detection is key in every type of cancer, right? It's not just prostate cancer. That's why there's recommended screenings for women with breast cancer and mammographies and all those types of things. And it's because we know the earlier you find cancer, your chances of survival go up exponentially. And that's why colon cancer screening is like, just go get the camera stuck up your butt, because if you got something and it's early, you're probably going to live through it.
Absolutely.
Colon cancer is not a great way to have to die.
No.
Because there is no cancer death that's a nice, easy death. It is a horrible way to die. It's hard on your family. It's hard on your friends. It's hard on you.
Financially.
Yeah. It's because it's such a long, drawn out disease, depending on, what it is and when it's diagnosed. But early detection is key. Absolutely, the number one thing that helps people survive cancer.
Because if you, 90% of the cancers are diagnosed and men have no symptoms. So if you're waiting on symptoms,
or waiting,
but
for
if you're
55,
or if you're waiting on symptoms for any cancer to get screened for, once you have symptoms, it's not good.
Yep.
Yeah.
Not good at all.
It's like the dentist. I mean, I don't. Those are very different sized apples. Let me.
But the comparison, I want to hear.
If you're sitting in the dentist chair and you got pain, you should have been there when there was no pain about
a long time ago.
Did you get yourself? Did you get your teeth cleaned twice a year?
Yeah.
Because they do X-rays every time they clean.
That's
exactly.
Okay. Yeah, because I mean, what was it? Somewhere like I think the PSA test or something like that was found at least 80% of some sort of prevention or early detection.
So I actually looked that up. So remember I talked about the sensitivity versus specificity. Sensitivity is a good diagnostic tool. Specificity is a good tool to rule it out. So this is up to date. This is kind of the resource that doctors, PAs, nurse practitioners, we use this frequently because it is literally updated whenever anything comes out. Like the new data rolls out, it's put on up to date. So a systematic review estimated that PSA cutoff of 4.0 nanograms per milliliter has a sensitivity of 21%. Poorly sensitive test. Not a good diagnostic test, right? But a specificity of 91% for detection. So that means it's good at ruling it out. For detection of a high-grade cancer, though, sensitivity was 51%. So that goes up, that doubles if you got high-grade cancer and your PSA goes up. But the high-grade is more rare than the low-grade. The adenocarcinoma is obviously the most common one. The positive predictive value is 30%, which is not good. So that's why it's a good screening tool, but not a good diagnostic tool, right? I guess we should make that clear.
Yeah.
It's a screening. It's not a diagnostic tool. Diagnosis is biopsy with positive or cancer cells on that tissue sample.
I think in the next 5 to 10 years, you're going to see more tests that have a lot higher sensitivity, specificity.
Yep.
Just like the 4K scoring.
So or a cascade of tests that'll help us trigger one to the next to the next. So
like right now with the 4K test, of course, it's not covered by insurance yet. Costs $750.
Yep.
Which I think is money well spent, but I get it. A lot of people don't have that kind of disposable money.
But $1 billion insurance company does.
Absolutely.
For some reason.
Check out our last episode for the medical.
When we're all
the
three
red
hanging
tape
out together.
on the medical. And I think by and large, what we're seeing too is that these are earlier and earlier ages than we had predicted. I mean, we've said that with testosterone. We've said that for a number of different cases that it seems like there's a real big opportunity to fulfill and serve this at a younger age in terms of prevention and awareness and research and data.
Yeah.
Early onset.
Yeah. As far as prevention, I mean, obviously we already talked about diet, exercise, smoking, excessive alcohol intake. I know a lot of people ask, well, are there any supplements I can take? Unfortunately, nothing great at this point. They did a lot of studies. At one point, they thought, vitamin E is going to be it, and then they actually found an increased incidence of high-grade cancers with vitamin E supplement. Selenium has always been the supplement that's touted. I mean, you'll find it in every multivitamin, et cetera. But studies really have not bore that out to be significant at preventing prostate cancer.
Yeah, and you'll hear Dr. Lapke and I always talk about studies, right? We are trained in an evidence-based medicine because that is what I believe is the best way to prove or disprove something, right? And the good thing about it is if you do, evidence-based medicine in 5 years, it might not be the same, but that means that we're doing a good job. That's the scientific method. You test and retest and you try to disprove, and that way we can do better. We can take care of patients better. So people are probably like, well, blah, 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 studies show this and blah, blah, blah. But we actually find pretty well reputable journals and try to read through these things and make sure because you can find a study that can prove anything, right?
Right.
These aren't from Reddit.
Yeah.
No.
Yeah.
These are actual.
But we could publish a study on whatever we wanted to, right?
Yeah,
it doesn't mean that it's actually true. We could put all the statistics in there that we want. But a lot of these are peer reviewed. So there's other researchers and doctors reading over the data and saying hey, this is not correct. You did this incorrectly. You need to repower your study this way, so on and so forth. So that's why we kind of talk in that lingo. It's important for people to understand that the evidence, evidence is always good, right?
Yeah.
And the COVID evidence that we always hear, I show a study showing what studies where?
Yeah. Who
did the study?
Right.
It's Joe in his basement with his brother and wearing their tinfoil hats. So it's not what we're here for. Right? We're trying to actually give you guys real medicine, real evidence to show that things are.
Well, that's why Josh referencing Up to Date. I mean, that is probably the most widely used source for medical information, most up to date studies. It's widely accepted by all providers, et cetera. So if you're quoting information from a site like that, it is very accurate.
Yep.
For the time. Like I said, it could change in 6 months, but that's science.
Yeah.
And people don't like to hear that, by the way, but
I know
that's just the way it is.
Yeah.
Fortunately.
Well, it's good that things change
because
and
if
we learn new stuff, or we wouldn't be where we're at in medicine.
We'd still think that asbestos was great, right? Well, this stuff great keeps everything nice and warm and cold. Why are you coughing up blood?
We would still be practicing.
Causes lung cancer.
We'd still be practicing bloodletting with leeches if we didn't have
Don't they still do that a little bit, don't they? What about the maggots on the they still do that?
Oh, yeah. For wounds,
yeah. You
absolutely.
put like on necrotic wounds, they'll put maggots on there.
Yeah, well, we would see cigarette commercials. Still.
Yeah.
It wasn't that long ago.
No.
I was not. I mean, they were on when I was a kid. Joe Cool and the whole. That was not that long ago.
Marlboro Man.
Yeah.
Didn't he die of lung cancer?
Yeah, he did.
I'm pretty sure he did.
He did. Yes.
What about Joe?
While we're on this, I always thought it was really funny, and I have to inject this when we're talking about Camel cigarettes. I always thought it was really funny that like when you smoked more, because you could turn in your miles, your Salem miles, your Marlboro miles, that if you turned in more, that they would give you a mountain bike.
Oh yeah.
Or a canoe. All the things that you would absolutely never do after smoking that many.
You wouldn't be able to.
Physically can't. Yeah, because your lungs are made.
I found that so ridiculous. But
your lung is like a wet blanket. Yeah. You can't absorb any oxygen whatsoever.
Yeah. Very good. So, what else should we cover? What else is important, relevant?
This is just a couple things real quick. I know providers, again, we throw out, healthy diet. Well, and we've said it here. What does that mean? I feel the best diet to follow for all health right now is the Mediterranean diet. Mm-hmm. Google it, Mediterranean diet. I think if anybody would follow that for any prevention, you couldn't go wrong. Josh, I don't know if
people are screaming at you right now.
Yeah, I know. Well,
that's a political stance.
It is.
Yeah.
Gosh, yeah. No, I mean, it's true, right? It's high protein, moderate to low carbohydrates, high fiber, healthy fats. I mean, that's
fruits, vegetables.
Yep, that's the one diet they've been able to show that actually does make people healthier through evidence-based medicine. So
amazing.
Yeah. So nobody's going to do it for you. There's no quick fix. Again, Walgreens, CVS doesn't have it. You can't order it on Prime. Amazon, they don't have it. You have to get off your tush
and do it.
And
I think one of the things we do need to really emphasize and highlight is that because it's a common question that I get in the clinic is, well, was this if I do testosterone replacement therapy, am I going to get prostate cancer? Mm-hmm. It's just not true. There's nothing that because we couldn't do it, right?
Right.
Like, why would the FDA allow people to take testosterone if there's proved that it causes cancer?
Yeah,
I mean,
it wouldn't.
It's it was causation.
Yes.
Right?
Yeah.
Like there was a correlation. You take testosterone, you got like a 7% chance to get prostate. I mean, it's almost laughable, right? When you just really kind of just go past the first layer of the onion and like I don't know what else to say.
Yeah.
It's that's again, that's what Dr. Lapke and I do. So that's important to us because we also want hopefully a lot of our patients listen to this. We want them to feel comfortable and know that they're safe taking it and that we're monitoring them, right? And if they do get prostate cancer, it's not because of the testosterone. It's either because of their age, family history, or lifestyle. Mm-hmm. But we have been actively screening that every single month, and we will send them to the places that they need to go once we get an absolute minor sniff if there's anything that's concerning. Yeah. So just want to throw that out there.
Yeah. No, it's part of the folklore that surrounds this kind of stuff.
Mm-hmm. Oh, absolutely.
All the misinformation, all the stuff that's driven to drive fear and away from the truth, right? And evidence-based truth, right? Which is clearly the best approach. But well, I think that we've done our part here. And again, the idea was to just normalize the conversation, provide resources, make this okay. And to speak to the guys out there who may be having some issues and maybe are getting a gut feeling they should go get something checked out. So thanks for your time again. And
you're welcome.
We always have a ball when you're on. And Josh, it's good to have you back too. But
man, good to be back.
Thanks for joining in, fellas, and we'll catch you on the next one. Cheers.
Thanks for tuning into the episode, guys. We appreciate you listening. Do us a favor, if you would hit the like button below and subscribe. You can also hit the little bell. That'll send you a notification when we post a new episode. In addition, if you have any questions, concerns, or comments, shoot us an email at hosts, that's plural, HOSTS, at menexplainpodcast.com, or go check out menexplainpodcast.com. Do us a favor, just share this with anybody you think that they would like it. We appreciate you tuning in. We'll catch you next time.